Hello, everyone. We'll talk about mental health in the primary care settings as to what can be done. So, basically, talking about psychological problem, cognitive issues. So, with respect to USA, this particular video will be projected as because that's an advanced countries and we all look up to that advanced developed economies as a model system. Even in US, approximately 42.5 million, that's 18% have suffered from any kind of mental illness. 19.7 million, that's approximately 8.5% have substance abuse. Substance abuse is alcohol problem or any drug problem. 8.8 million, approximately 3.77 percentage have serious suicidal ideations. In 2012, 8.1 million Americans with mental health issues were uninsured. Look at the magnitude of the problem. One in four adults have mental health issues. One in five children have mental health issues. One of every five Americans takes psychotropic medication thereby. Why is there such a high number of patients seen in the primary care of mental health? This is the question because there's a shortage in mental health provider. It is estimated that there is one mental health provider per every 790 people, according to a report that has been published by Mental Health America. The reasons are lack of insurance coverage for mental health stigma per se, the dilemma to treat or not to treat. One physician stated, this winter I'll see more patients with seasonal affective disorder than the flu, and the tissues in my exam room will dry tears more than they muffle sneezes. Or she expressed the concern about treating so many mental health conditions and stated, I lack the time and training to diagnose and manage psychiatric disorders. That is exactly what we need to do around here. What is to be done as far as mental health issues are concerned? The medical professional are in a catch-22 situation. Reason to treat. If a patients are not treated in a primary care, many patients suffering from mental health issues will go without being treated at all. Increasing demand and decreasing number of provider. Psychiatric disorder affects the patient's physical health. A patient that is under undiagnosed or untreated mental health condition is at a risk of suicide. Patients are resistant to seeing mental health provider or they do not perceive the needs. Presence of mental health conditions leads to poorer health outcomes, increased mortality, consequently to the society and a lower quality of life for your patients. What are we looking at as mental health? There are emotional issues, cognitive issues, and physical issues. The manifestation as of emotional are sadness, anxiety, irritability, lack of enjoyment, suicidal ideations, hopelessness, and guilt. That's the emotional issues. What about cognitive? Difficulties with attention and concentration, short and long term memory, decision making, planning and organizations, mental sharpness, word finding, thinking speed, judgment. What is the physical requirements? Is fatigue, eating changes, insomnia, headaches, stomach problem, chest pains. Remember, emotional symptoms are affect the mental health and the physical health or vice versa per se. We just cannot support one from another. We must assess and treat the whole patient for the best result. Social and spiritual aspects of patient life should also be considered. Reason to treat. Appropriate treatment leads to increased productivity, better parents, better students, improved medical outcomes, and increased independence of the elderly. It is recommended that by multiplying the health care organizations, including surgeons, General Office, Institute of Medicine, New Freedom Commissions. Not all mental health conditions are complex. Many are simple to address and simple to probably diagnose also. Conserve specialized resources for more complex patients that needs them most. Many times, new patients have to wait 1 or 2 months to get to an appointment, or provider adjust their schedules to see patients to be seen right away. So the question is when to consider referring to a mental health provider. Delaying referral may impair recovery and overall outcomes. They are not formal guidelines. When a patient is not treated properly or has multiple medication that were either not appropriate or tried to therapeutic level, it seems to lead to a hopelessness and a distrust of psychotropic medication in general. So always try to refer a patient with mental health issues to a therapist and probably or support group, AA, Anonymous, Al-Anon, Grief Support, Celebrate Recovery are such examples of mental health groups. Most patients will have a greater outcome. They receive medication management and therapeutic interventions. You should also refer a patient probably when the patient seems to be having a more complex condition or has multiple psychiatric diagnoses such as depression, anxiety, substance abuse. Many patients have two or more diagnoses. You do not have adequate desire, time, knowledge, resources to adequately treat them, or you're unsure of the diagnosis. The patient states that they have already tried multiple psychotropic medication, or if you have tried several medication and they do not seem to be helping, or they are having a side effect, you have prescribed up to your comfort, to your knowledge level. The patient expressed suicidal or homicidal ideation. The patient is having psychotic symptoms. It seems to be a chronic long term condition that will require a long term solution. The overview common myths about mental health status examination, most common diagnosis, signs and symptoms, the diagnostic criteria, most common psychotropic medication, prescribing trips and guidelines, serious potential conditions associated with psychotropic medication and other potential treatment thereby. Myths about mental health. Patients with the mental health issues are usually violent. These are all myths, mind you. The truth is, most patients with mental health issues are not violent. Mental illness is a character flaw that they will grow out of or pull themselves out of. The truth is that most mental health conditions are brain disease that may not be getting any better without proper treatment. People with mental illness are capable of making rational decisions. Most patients with mental health issues are functioning very well and able to make decisions and take care of themselves just about fine. Psychiatric medicine makes people become mostly like zombies. The truth is, the proper medication management should not only make person feel like a zombie, but should help them to function more efficiently and have increased ability to concentrate. If the medication has negative side effect, it should be adjusted or changed. Making a diagnosis, mental health, mental status examination, general behavior, complaints, polite, hostile, intoxicated. Appearance, well dressed, disabled, hygiene, level of consciousness, alert, oriented, lethargic, attitude, speech, volume, tone, rate, psychomotor activity normal, hypo or hyper, tremors, pacing, mood and affect, angry, sad, anxious, labile, thought process and content clear, intact or delusional, hallucination, describe and judgment. Are they aware? Are they acting about it? Pathophysiological of mental illness. Mental illness is diagnosable disease of the brain that affects a person feeling and thinking and behavior. It is a disease that's psychobiological in nature and is influenced by genetic, biology, and environment. There are three major types of neurotransmitters in when I say neurotransmitters, they are nothing but chemical messengers that can produce mental illness when they become imbalanced. Most psychotropic medication either increases or block the effectiveness of neurotransmitters in the brain and are synthetic versions of the chemicals that are found in the body thereby. This is what we are looking. Most of us are talking about dopamine, as in excess of dopamine, we become more energetic, reverse pleasures, obsession, movement. Depression is mental health problems have depression, ADHD, SX, Parkinson, EPS, or schizophrenia and mania. What about the chemical, or should I say the hormone serotonin, which is all about depression, sleep, appetite, libido, anxiety all goes down. That is depressive symptoms. Anxiety symptoms, serotonin would increase it. Norepinephrine, concentrate, fatigue, similar to adrenal and memory recall. It is all about a depression which decreases cognitions, fatigue, ADHD, mania, and insomnia, which goes on the higher end. So, what is it? Neurotransmitters are chemical messengers. Look what we are looking into it, which transmit information from nerve to nerve across the synapses. They are released at the presynaptic nerve ending and attached to the receptor. Medication can either inhibit or stimulate neurotransmitters in postsynaptic cleft, as the case might be. This is what we are looking out here. Common psychiatric diagnosis and treatment. List of depression orders according to DSM-5: a premenstrual dysphoric disorder, unspecified depressive disorder, other specific depressive disorder, disruptive mood dysregulation disorder, persistent depressive disorder, substance or medication induced depressive disorder, major depressive disorder, single or recurrent uh, episodes. Now, these are the diagnosis. Now, what happens if the symptoms impaired ability to think, concentrate, or make a minor decision? Sleep disturbances, insomnia, significant weight loss or weight gain, perhaps less energy, tired, fatigue without any physical symptoms. Symptoms can cause significant distress or impairment in social occupations and other areas of functioning. Thoughts of death, not waking up in the morning, others would do it better without me, planning and preparing for suicide. Now, these are what we are talking about is the mental health issues or things. Remember, five or more of the following symptoms must be present nearly every day during a 14 days period. Core symptoms, which is more than one, as in depressed mood, anhedonia, additional symptoms, clinically significant weight loss, insomnia, hypersomnia, psychomotors, agitated, fatigue or loss of energy, feeling of worthlessness, excessive inappropriate guilt, diminished ability to think, recurrent thoughts of that, and so on and so forth. So, does the patient really have to be taken care of? Yes, definitely. In cases of major depressive disorders, five or more of the following symptoms would be present, as I have stated. Dysrhythmic disorder, predominantly depressive mood and other depressive symptoms, as in always feeling sleepy, always feeling guilty, not talking up, not being social. Now, bipolar disorder 1 and 2 almost similar, but in bipolar 1, you have the frequency is of less, approximately less of a mania, as in inappropriate behavior, as in erratic issues, erratic responses, mood variations. In bipolar 2, is the same symptoms but much more frequently. Similarly, for cyclomatic disorder, short period of mild depression, hypomania, lasting a few days, separated by a short period of normal mood. So let me give them, as far as bipolar disorders diagnosis and treatment are all about it. Remember, bipolar disorder is a chronic and a complex mental issues characterized by periods of mania, hypomania, alternating with periods of depression. The world's sixth leading causes of disability is bipolar disorder. Approximately 25% to 50% of bipolar patients attempt suicide, and about 15% complete suicide. Average of 8-year delay between the first presentation and the diagnosis. Up to 30% of the patients are presenting with depressions or anxiety issues with bipolar disorder. Misdiagnosis can lead to the effective treatment or adverse treatment of outcomes. Bipolar 1 disorder is defined by maniac episode that least at least in the 7 days, or by manic symptoms that are so severe that the person needs immediate hospital care. Usually, depressive episode occurs as well, typically lasting at least 2 weeks. Episode of depression with mixed features, having depression and manic symptoms at the same time, are also possible. Bipolar disorders defined to be depressive disorders and episode, but not the fully blown episode described above altogether. Common symptoms. Psychological, we are talking about tensions, worries, panic, feeling of unreality, fear going crazy, fear of dying, fear of losing control. But what about physical thing is trembling, sweating, heart pounding, dizziness, lightheaded, muscle tension, nausea, breathlessness, numbness, stomach pains, tingling sensation. We'll talk about ADSD before we wind up this video. ADS, uh, AD is acquired attention deficit. I just would like to go around it. Remember, ADSD is not a disease per se, and what we are going out here, no, ADSD is attention deficit hyperactivity disorders. Attention deficit hyperactivity disorder. Remember, it's not a disability, but it is a different kind of ability. The surprise benefit of ADSD is unrivaled passion, thrive in intensity, good at multitasking, creativity, visionaries, charismatic, high IQ, high energy, more fun. So bipolar disorders and ADSD, attention and deficit and hyperorder disorder. So we are talking about disorder. There are severe mood swings, but ADHD is inattention hyperactivity. What are we looking at in bipolar thing is elation, racing, racing thought, rapid pressure speech, risk taking behavior, tantrum, aggression, rages, low need for things, hypersexual. On a negative side, lethargic, sad, depression, separation, anxiety, and suicidal thought. But about ADHD is distractible. Many have an anger, rage is rare, mood changes, appropriate behaviors are redirected. Remember, attention deficit hyper activity disorder is all about being continuous. So, what if these are the exclusive features of bipolar and ADHD? What is common between them? Irritability, hyperactivity, restlessness, impulsiveness, oppositional, increased energy. With this, I come to an end of this video. Thank you for watching it.